I'm very pleased to have this opportunity to present our work on the outcomes of obstetric brachial plexus injuries. We've looked at over 100 cases in patients over 5 or over with permanent OBPI in Bath. Just a reminder of the gradings which are wisely used of increasing severity, but I tend to prefer the concepts of incomplete and complete injuries. We reviewed the outcomes in the upper limb for a range of problems. So far, I've done all the assessments. We've got over 8,000 data points, and I won't give you all of them, but we're looking at subjective and objective outcomes. Subjectively, pain, stiffness, altered sensibility, strength, and cosmesis. And objectively, ranges of motion actively and passively, strength, development of the upper limb. So here's an example comparing thumb sizes and looking at the spine because of the suggested association with OBPI and scoliosis. So the results. In this, I've highlighted text that I think is new information not previously known. Pain, almost always around the shoulder. Most people had some pain, but only in a small number is it very intrusive. It appears to be a mechanical rather than a neurological problem. Almost all had some stiffness, particularly in the shoulder, but very few people had reported altered sensibility unless they had a severe, complete OBPI, and that really is a function of cerebral plasticity. Almost all had some loss of strength, except the mildest cases, and there was a cosmetic abnormality that tended to be proportional to the severity of the injury, but not always. Objectively, we looked at a number of things. So first of all, the shoulder. There's almost always a loss of range of motion. Only the mildest cases don't lose some abduction or flexion, and virtually all lose some external rotation, more in adduction than abduction. And so classically, they have this trumpet sign, as on the left, when getting their hand to their mouth. We noticed that all lost internal rotation, which has not been reported before, and this was proportionately greater than loss of external rotation. And this shows that this is really a global contracture problem, not a muscle imbalance. And the contracture can increase into adolescence. In the elbow, active elbow flexion, i.e. biceps function, virtually always returns unless patients have operations early. Others have shown this, and this is very important, moving us away from too much surgery, which we've been advocating, i.e. a more conservative approach for decades. An elbow flexion contracture is common, and it increases into adolescence and may need to be reviewed. The forearm, there's usually a functional range of motion. Supination is linked to shoulder external rotation, as we published 20 years ago. But we found no link between forearm and shoulder contracture, suggesting these are different mechanisms. And you see here in this child, lack of shoulder external rotation and a lack of supination, and they're linked. In the wrist and hand, we showed that for the incomplete ones, they almost all have a functional range of wrist motion, i.e. wrist extension of 30 degrees and flexion of 10 degrees. They all have full hand movement, and the ranges of motion don't change after the age of 5. Interestingly, hand dominance was retained in about 26% of incomplete injuries. With the complete injuries, they lost wrist extension the majority of the time, but mostly retained wrist flexion. The hand ranges of motion were typically incomplete and always incomplete with if they had a Horner's syndrome. So this is a reliable predictor of a very poor outcome. Strength decreased with increasing grade of severity. We found that they required 67% grip strength on the injured side compared to the other side to have dominance on that side. That didn't mean they would, but it's clearly a factor in hand dominance. The upper limbs were underdeveloped, as we noted. We've shown that there's minimal or no effect on the hand for incomplete OBPI, but when complete, there's always some underdevelopment. And you see here in this young man, some narrowing of the shoulder girdle in particular, shortening of the upper limb, especially proximally. And you'll also notice some underdevelopment of the pectoral muscles. We also looked for scoliosis. There was some postural scoliosis, particularly in the older children, but none had a fixed scoliosis. And you see here a mild curvature emphasized by the high riding right scapula, but in flexion, there's no fixed scoliosis. So in conclusion, early brachial plexus grafting is more dangerous and less useful than we thought. It's likely that later nerve transfers are better. Shoulder stiffness is primarily due to contracture and not muscle imbalance. Stretches from early should include internal rotation stretches as well as external rotation. And shoulder surgery should be primarily aimed at releasing the shoulder rather than performing tendon transfers. Elbow contracture is a progressive problem, but we don't really know how to treat it. There may be a role for splintage, but probably for many years. Hand function can be reliably predicted to be good in incomplete OBPI and poor in complete. And scoliosis is not obviously a risk factor for OBPI. So if you see patients with this, we'd be very happy for you to refer them up to us, as we would for all brachial plexus injuries, which we now treat. Thank you very much indeed.